Over the past few weeks, we've seen various different reports come out around general practice. There's been the contract changes, but there's also been some other documents as well. And in this episode, we're going to have a look at the Hewitt Review. This is looking at integrated care systems and what they potentially mean for the future of general practice. And this episode, we're going to break it down so you can hopefully understand what it means for you in primary care. Let's take enhance your primary care and learning.
Good morning, ETP learners. Morning, Gandhi. How are you doing out there over in the other side of Nottingham?
Yeah, ticking on as ever. Still getting through Ramadan, but only a week to go, and then we're through all of that and stuff. So yeah.
Yeah, fantastic. So another week, another report. So it's the Hewitt report this week. This one feels like it's quite a big one, Gandhi, doesn't it? There's these reports always make headlines. I feel that this one perhaps hasn't been discussed as much as some of the other more recent reports, but there have been some headlines that have come up. Major government review suggests an international GP contract is the gist of most of them. And that's one of the big suggestions within this report. So I think it is quite a big deal, and I'm really glad that we're discussing it this morning, and really interested to see what people make of it out there. People might have read it already or read the general practice elements of it. People might be meeting this report for the new time, but really for the first time, but really interested to know what people think about it. Just to give people an overview of how we plan to approach the session. So we're going to be looking through the report. It's about an 80, 90-page report. So we're really going to be focused today because we think actually what is said about general practice deserves some discussion and exploration. But we're going to take our usual approach, just familiarize you with what's in the document, but then we're going to, by looking at the contents page, but really going to focus on the foreword from Patricia Hewitt, terms of reference, the executive summary, just highlighting really that the content of the report is, for the most part, it sort of feels quite predictable. There's an emphasis on a focus on health promotion, disease prevention, and shifting the focus of care in that direction, and about equipping ICBs and ICSs with the tools, the powers, the responsibilities that they need in order to deliver on that. But there's this section on unlocking the potential of primary and social care and building a sustainable skilled workforce. And then there's section on primary care, which we're really going to focus on in detail because there's quite a lot of discussion about GP contracting models there. So buckle in, and that's how we plan to approach things. Gandhi, happy with that approach?
Yeah, we're going to crack on and basically have a look at this document. Important to note, there are some other things coming out as well imminently, so there's that, as well as other documents that have come out, which we are going to be reviewing in coming episodes as well. So there's the Health Foundation report on GP stress and burnout. That will probably be our episode next week, so do check back for that. And also that long-awaited GP access report apparently is going to come out shortly after the local elections. The reason I believe it's been held is because of PERDA, because of the elections and stuff. So it will probably drop the day or so after that. So let's see what happens from that point of view. But this one, like you said, Andy, is really interesting because it talks about integrated care systems. So I guess a bit of history. It was commissioned back at the end of last year, November time. And it's got some interesting history in it, hasn't it, Andy?
Well, yeah, it's always interesting to look who's writing these reports. So I guess the thing to say, so it's government commissioned report. So the Parliament, the government structures have commissioned this report. It's an independent review into the latest NHS reforms, into the creation of ICSs. So that's interesting. It's led by Patricia Hewitt. So people might not remember Patricia Hewitt. I'm not sure I fully remember it actually, but she was a Labour Health Secretary between 2005 and 2007. I think I've not looked back too much at her tenure, but I think there was some controversy around that time. If I remember, I was a very, very junior doctor at that time, and I think there were some waves made. But Patricia is so just, I guess, picking up in the forward, really. She's currently the chair of Norfolk and Waverley NHS Integrated Care Board, deputy chair of its Integrated Care Partnership. So she is operating and working within this space. She's acknowledging that she's a previous Secretary of State for health there. Why has this been done? So, or what are they looking at? It's a review to consider how things are going with ICSs and where things should go in the future. Just before we get into the weeds, actually, it's interesting. So she's a Labour politician, isn't she, Gandhi? And a lot of, we've had reports from From Jeremy Hunt, recently we've had things from Savage Javid. It's interesting just to triangulate the tone and the direction, the emphasis within these reports, particularly when it comes to general practice and general practice contracting. And she is also saying things which suggest changes coming to the way GP contracting is
Oh
handled.
yeah, definitely.
The GP partnership model is still mentioned and talked about, but there is an emphasis on other models. And it's interesting that a Labour politician is also reaching these conclusions. So I think we can say that there is now a cross-party consensus for big reform in the way that GP contracting is done. And I think that that's significant, just to mark there, really. So just highlighting that the ICSs have 4 main aims, just worth recapping those, I think: to improve outcomes for population health, and the healthcare outcomes, to tackle inequalities in outcomes, to improve experience and access of healthcare, and to enhance productivity and value for money. So those are some of the main headline priorities of ICSs. And then she just talks a little bit, actually thanks other people involved in the report, but this session just highlights that they have taken a lot of submissions from people. There was a call actually towards the end of last year for submissions. Often those go a little bit unheard. And Gandhi and I were talking when we were preparing, weren't we, Gandhi? We might actually want to be involved or try and make contributions to some of these future reports. And there are breakout boxes where she takes some of these submissions and includes them.
And the case study examples and that kind of stuff, and goes into more depth around them. And we'll cover a couple of those shortly as well.
Yeah. So, and then she's talking about the other reports that she's drawn, work that's gone before her, full of stock take, messenger review, work from the King's Fund. So, just highlighting some of the process that's gone into the report there, really. So that's the foreword. The terms of reference are interesting to look at, because this is why has this review been convened, really, in this report produced. So they're looking at how oversight and governance of integrated care systems can be put in place to best enable them to succeed in their aims. And in particular, the scope of this report is to look at how to empower local leaders to focus on improving the outcomes for their populations and give them greater control, and also make them accountable for the performance and the money that they manage. To look at the scope of options, to look at the target culture, really, number of targets, types of targets, and make some recommendations around targeting and prioritizing that comes down from NHS England to ICSs, and also looking at the role of the Care Quality Commission, which actually it's a big part of the report in its own right, but something that we've chosen not to focus on in this episode. And then finally, the executive summary, and really it's just you can really look at the headings, really, and just pick a few things out. But this is saying that she's identified 6 key principles to focus on to enable ICSs to deliver on their objectives. So a key theme is focusing on prevention and promoting health, shifting the focus upstream. So increased focus on people before they develop disease, or whether in the early stages of their disease, often in the community, before their disease and their ill health progresses to the stage when they are in hospital and needing secondary care. These are not new principles, but she's just adding some emphasis to that. Interesting call for the share of the total budget spent on prevention in each ICS to be increased by 1% from what it is already over the next 5 years. That's an interesting, very specific call. Increased use of data, and empowering the public through the use of the NHS app to empower them to manage their health better, which is a positive, in my opinion. Next of the 6.
Interesting, Andy, though. Increase by 1% over the next 5 years, moving towards prevention, to me, doesn't sound like a lot, to be honest.
Yeah, and I thought, I wonder what the baseline is in different areas as well, because some area. I mean, probably she knows what the baseline is, and maybe it's similar, but a lot of variation. It might be that some areas have it almost. Maybe some areas are doing it fairly well, and a 1% increase, is that appropriate for the area? Another area might have a much lower emphasis on prevention, and actually a 2 or 3% increase in spending on prevention be a better objective for them. So it's interesting that they picked out a specific figure, but nonetheless, they have.
Mm.
Yeah. So delivering on the promise of systems. So
Mm.
she's really keen on ICSs. You'd think she might work for and within one, and she does. But she's highlighting that actually bringing together responsibilities for the interconnected areas of health and the different aspects within that and social care together in one body that is responsible for the delivery of all of that is logical, and also bringing together the providers that provide that, local councils as well as NHS bodies and so forth. So she thinks there's a lot of potential in that, and it does. There's a lot of logic in those thoughts. She's talking about giving people space and reducing the number of national targets, no more than 10 national priorities. So I think a lot of people will probably welcome that.
Mm.
And she's talking about greater autonomy, greater decision making at the ICS level. That's really a focus of the report, and always talking about data to manage and guide performance. Another area, unlocking the potential of primary and social care and their workforce. So the main thrusts here are trying to remove some of those barriers between health and social care. So she's talking about passporting of skills, a greater role for ICSs to have a greater role in the training of care staff, essentially, so that those skills can move into the health sector and back and forth, and so that health can move tasks out of the health sector and to the care sector. That makes a lot of sense, thinking about how we interact as GPs with care homes, for example. There may be things that our healthcare assistants do, like go to the care homes to take blood, that maybe actually care staff could do in the future. So, reducing those barriers and improving the portability of skills and recognition of skills does sound like a positive. Okay, we're talking about a new GP contract framework, so we will talk about that. We will talk about that later, but that's a big emphasis of this, and that is the big deal, I think, or the biggest deal for general practice in the report. Just completing these areas of focus or priorities, resetting our approach to finance and embedded change. So I think she's talking about simplifying finance and moving towards population-based budgets for delivery, which I think is interesting. We're used to those in general practice, aren't we, Gandhi? Perhaps secondary care are less used to operating on population-based budgets. That's quite a big thing. And they also talk about, I don't think I've highlighted it, but there's a discussion in the finance section about trying to move away from giving some single year pockets of funding for specific things, moving towards more predictable multi-year funding for healthcare, which I think would be welcomed by everyone, really.
Many,
yeah. So that's that. Any reflections there? While I from yourself, Gandhi, or the audience out there, that's just given us an overview of the document, I guess, and I'm just about to skim and point us at page 64, which is where we start to deal with primary care. But any thoughts from yourself or people out there?
I think we'll get a lot of it into the detail shortly, and particularly we mentioned there's two big things that come through from this. So the look at targets and that kind of stuff, and also the GP contract and things. As Andy mentioned, we're not going to cover the rest of this document because some of this doesn't really apply to general practice. It's wider than that. And to be honest, if we were to do the whole document, we'd be here for a good hour and a half, to be honest, which is probably more time than we can dedicate to this. But we're going to take a focus actually on the primary care element of this. And it's interesting, some of the stuff that's mentioned in here. As Andy mentioned, there's some strong language in this document. And I think it'd be really interesting to see what the government's response to this is, because obviously one thing to remember, they haven't responded to some of the earlier documents that we've had. So yes, there's been some sort of response to fuller stock take, and that's mentioned in this document. We still haven't seen an official response to the Health Select Committee report, the one that was written by Jeremy Hunt. And obviously, this is another document that is now making waves as to how general practice should be operating. And obviously we're waiting for this big whole access report that we mentioned. Hopefully it's going to be out in the next couple of weeks or so after the local elections and things. So shall we crack on with this one?
Yeah, absolutely. So this really is the most important section, I think, for general practice, and what some of the headlines were based on. So just walking us through it. So they're talking about, there's a big emphasis on strengthening local leadership and their ability to manage primary care and social care. And by primary care, there's an emphasis on general practice within that as well. So they're calling for more powers for local leaders. Talking about pulling down some of the barriers that exist in the way we train the health and workforce. So we were talking about that when we were picking up that in the summary. So talking about that's the portability of the skills between the two. Now, primary care. So references the fuller stock take and the vision within it and the route map. There's a big emphasis on the PCN level for local delivery. So there's talk again about neighborhood teams and primary care networks, and a focus on, I think, funding attention, at that level. There's just prominence given in the report, that level of care, I think. To build on the recommendations of the fuller report, focusing on what needs to be done to create these neighborhood teams and integrate care, integrate the whole patient pathway across these neighborhood teams. So I think primary care networks have begun to, in some places, move towards that sort of neighborhood team approach. In other cases, I think primary care still looks quite similar to how it did before, with some bolt-ons, but there's an emphasis on moving us all to that sort of integrated work.
I think this is probably one thing to pick up on. For a while, the past few, 4 or 5 years, we've heard PCN, PCN, PCN. Actually, I think we're going to hear a change in that nomenclature to INT, so integrated neighborhood teams, and whether that's what the future of PCNs is going to be is a potential. But it's going to be interesting to see how that develops and stuff, particularly with some of the language and the tone that we see in this particular document.
Yeah. So just remind us that the fuller stock take did not talk about changes to primary care contracting. And if you remember, there was some sentences within that saying this is out of scope of my report from Fuller. I say the information will come later, and I think this is that information and those recommendations, essentially. So that's just interesting to point out. Highlighting that ICBs are taking over responsibility for community pharmacy, optometry, NHS dentistry. For the first time, they will all be controlled in one place. There are opportunities there, breaking down silos. Okay, so it feels like we need a drum roll coming up to the bit where they talk about primary care contracting.
I think another thing to point out, if you look at the tone of the language here, this suggests to me that this was written well before it was actually released, because don't forget this was released literally just before the 1st of April. So I think this has been ready for quite a while. It's just been held for whatever reason. But I think that's one of the things I picked up when I was reading this particular document. The dates wise, it does seem to be a bit weird in the way it's been written.
Yeah, sort of. It's almost like that's in the future, isn't it? On the 1st of April, all ICBs will take control. So yeah, it gets the sense of something that's been held back for some strategic reason, potentially. Okay, right. So this is where we start to hear some of the language around primary care contracting, despite currently being constrained by nationally negotiated and held contracts. So there's language around ICBs being constrained in what they're trying to do in primary care by the national contract. So that's interesting tone, I think, quite negative about national contracting and nationally negotiated contracts, and that continues. ICBs should play a greater role in driving primary care transformation. So I think for the most part, in the past and in the kind of current primary care network era, the emphasis has been on primary care, local primary care leaders, primary care network boards and practices to really sort of drive and feel responsible for the transformation happening in primary care. This could be different in the future. ICSs should play a greater role in driving primary care transformation. I think that's really interesting. Lots of mentions to delivery at scale. I just wanted to highlight that there, essentially. And primary care.
And then it mentions one of those case examples, the Medicus one. So this is an example of apparently the second largest GP practice in the country, with the largest one being Operos after its takeover of 80 Medics and stuff. And we've covered that in one of our early episodes. But this talks about, links to London Borough practice, 15 practices merged, how they've shaped their estates and that kind of stuff to help reduce A&E admissions and various other things. It's an interesting case study to have a read of, to be honest. But yeah.
So this is the big bit now, talking about primary care contracts in the Hewitt report. She's heard repeatedly national contracts present a significant barrier to those within GP partnership model who want to work in an innovative and transformational way. And then she's also acknowledging that a great deal of time and goodwill, and workarounds are used to make the current situation work, which I think is true. Gandhi, what do you think about this statement that the national contract presents a significant barrier? What do you think about that? Do you agree?
I'm curious to know who those people are that are saying that, because it's an interesting perspective to take on the way that the contract works. I think the contract does work and doesn't work in places, but I think also that's what we currently have. If they're talking about making a more local variation of the contract, what does that mean in terms of the experience that patients have? Because often what we hear from the government is they want a universal experience for patients, and it's a bit hard to understand how you can have a universal experience for patients if you have multi-modal kind of contracts on a regional basis, which actually I would agree with, to be honest, because I think different populations need different healthcare needs. But then if it's all financed through one contract, I can understand some of the perspective, but I'm also curious to know, who's been saying that?
Well, it's interesting. I mean, I think in some ways it's us, isn't it, Gandhi? Because we talk about how the current status quo doesn't work and isn't working. So whilst it feels threatening, in some ways, I think we've been critical of the status quo as well. I think we're apprehensive about what might come afterwards. I also think it's interesting because I don't think we have been critical of the status quo, but I don't think we actually necessarily criticize nationally negotiated contracts or the concept that it's nationally negotiated, which is what they've singled in on here. I think we're more sometimes negative about the current formulation of the nationally negotiated contract, and maybe we'd like to see changes there. But that concept of having a professional negotiating team from the BMA and the GPC negotiating a sensible national contract and and level of service from the government. I don't think we've disagreed with that. So I hope that a few things are not being conflated together into one thing to present the impression that GPs are not happy having a nationally negotiated contract, because I don't think that's.
Yeah, I mean, it depends on the perspective she's taken, isn't it? Because I mean, if you look at it from a historic point of view, we're now in the second year that the GPC have not agreed with the current contract. So that does have some impact in the fact that that says the profession is not happy with the contracting mechanism we have. Does that mean that it is a barrier to innovation and transformation? That's the part I'm struggling to understand, because actually I think that happens independent of the contract anyway. Like I said,
I think so. Yeah. And there may be other things that are barriers to innovation and transformation that might be
like the fact there's not enough resource to do it.
So I don't know if are we being sort of set up a little bit here for something. I don't know. I think that the more paranoid of us might begin to think that. But it's interesting also, and I was going to talk about this in the discussion, but I do wonder if actually the deterioration in delivery from primary care, or at least the perception that primary care is not delivering as well as it used to, it sort of happened. Okay, the pandemic's been in the middle, but it feels like it's happened over that time period where actually we've moved away from contracts which have been nationally agreed and by the GPC and properly nationally negotiated, and towards actually more local decision making and delivery, and contract imposition outside of the core contract in the form of the PCN DES contract, amongst others, and that actually that's the period of time that we've seen the deterioration, which they're trying to reduce, and suggesting that the solution might be more of the same. I don't know. I'm just throwing it out there. Correlation is not always causality, is it? We know that as medics, but interesting. So what are they going to do about it? So
well, it's just worth going up a little bit further, Andy, if that's all right. So one of the things it mentions here, 4.10, ICBs take on responsibility for NHS dentistry as well. Now, some may remember a while back when Teresa Kofi released her report, the four something or others. I can't remember what it was exactly. But on that, there was a focus on dentistry and some of the contract changes that they were making towards NHS dentistry. And this does put quite a significant focus on making sure that locally ICBs tackle the really poor provision of NHS-based dentistry currently across the whole country and stuff. And that does have an impact on general practice, because we are increasingly seeing more dental issues present. And actually, we know that poor dental care as well leads to poor general health care as a marker and a correlation of those kind of aspects. So I think that's really important, that there is a focus being taken on that the ICBs now need to really crack on with their responsibility of dentistry as well.
Yeah. Do they have the tools to address that?
Well, that's the question, isn't it?
Yeah.
How much they have the ability to pivot on a lot of this, particularly given the fact most ICBs are, massively posting over expenditures and that kind of stuff, and having to make cuts left, right, and centre as well. It's going to be interesting to see how that works forward.
Yeah, absolutely. I see we've received some questions. Is it worth taking those as we go along, or?
Yeah, let's go for it. So it's from Dave McConnell. Thank you for joining us again, Dave. Do you think the move to ICB from CCGs put less GP in leadership roles, so highlighting frustrations from other professionals? I think that's an absolutely valid point. CCGs were traditionally clinician-led, GP-led organisations. Although it was a bit of a misnomer, it wasn't GPs actually leading for general practice. It was just people taking those positions that were trying to do the work, but obviously their focus was still very much on delivering what the government was saying that we had to deliver. But I think it's allowed a different perspective to come in, and then those different perspectives sometimes do align, sometimes don't align, and sometimes can be productive and sometimes can be destructive as well, in my view.
I agree with both of you, really. Yeah. I'm going to crack on. So more strong language, got the red highlighter out here. So furthermore, contract held by GP contractors for general medical services, which is negotiated nationally between the government and the BMA, provides far too little flexibility for ICSs to work with primary care to achieve consistent quality and the best possible outcomes for local people. So quite negative about that nationally agreed contracting model, where the same contract applies elsewhere, and perhaps the protection within the contracts for the providers and the GPs, which prevents ICSs from when they say working to achieve consistent quality. Often that's contract management, which is shorthand for putting pressure on practices. I guess it's interesting because I think you can both sort of agree and disagree with that, or see both sides really, because it does give us some protection having those nationally agreed contracts, and maybe there might be more that ICSs would be doing to improve, this consistency and quality in some cases if they had more powers. But equally, you do worry about whether they have the right skills, locally to administer those and to get the contracts in the right place for local people. These are some powerful statements. I'm interested to know what you think about that, Gandhi, that balance.
I think it's a tricky balance to achieve, and then it comes down to the strength of the local negotiators and that kind of stuff, which is so variable. I mean, who do you have around that table? Is it the LMCs? Is it the practice representatives? Is it the federations? Is it the PCNs? Is it, wider than that in terms of social care and other things? And I think that's where you get so much broader aspects of how do you manage it. And also, how do you tackle, really granular variation? If you compare, where we work, for example, Andy, I work in the inner city Nottingham, where a mile down the road, you're suddenly in one of the most affluent areas of the Nottingham, compared to where I work is one of the most deprived areas of Nottingham. And that geographical difference makes it really challenging to come up with locally negotiated contracts that balance the two different needs from those different populations.
That's a really good point, Gandhi, because just because, you could create a contract more locally, actually that doesn't mean that there isn't just as much diversity within a local area, because we're only a few miles apart, but vastly different populations. So even a local contract wouldn't necessarily take account of the diversity in population groups between our two practices. So that's really, really interesting. I mean, unless they're going to individual contracts for each general practice, I mean, God knows how that would How that
I can't imagine any
how that would
ICS
work.
would want to look at that, because
Yeah.
the number of contracts they would have to hold. I mean, for Nottingham City alone, we're talking potentially 44 plus contracts. Then you go to county and wider, you're talking over 100 different potential contracts looking to manage, and no one has that kind of capacity to deal with.
Yeah, but yeah, interesting. And then they give an example of when national requirements can have unintended consequences, but they don't choose an example from the GMS or PMS, national
No.
contracts. They choose an example from the PCN DES, which is that level of organisation and funding which is being sort of pushed and promoted. So it's interesting that they choose an example from that as a negative thing, although it was a nationally applied contract, and they talk about the unintended consequence of really pushing primary care networks to recruit clinical pharmacists into their teams, and the negative effect that this has had in some areas in terms of depleting the number of pharmacists available to work in and run community pharmacies, which are obviously vital for the health of people because they dispense
Yep.
people's medications. So that's interesting, and I guess the principle is, national bad, local good, but also perhaps a conflation between, what is the core contract that they were talking about in the paragraph above, and and what is actually a different contract that they've actually been pushing through government without engagement with the BMA. The BMA probably or may have warned against these sorts of consequences, so it doesn't necessarily mean that that national negotiation with expert GP negotiators is a flawed model. But there we go. So just highlighting there's an opportunity for ICBs to integrate primary care offer for communities. So it's about system level integration of the whole primary care offer, and making the best use of staffing and premises. This feels like a push towards scale where that's agreed and appropriate in different areas. So just highlighting that in terms of a change. We've heard many times reports coming out from government and parliament talking about how QOF maybe did something positive at the time in terms of moving quality and standards, but that now seen as inflexible, focused on activity rather than outcomes, and that actually this might be a line of funding and a contracting model that's going to go away. So that's another signal that QOF's probably for the chop the next time the contract is renegotiated.
Or at the very least, a metamorphosis into something completely different. But yeah, it'd be interesting to see what that change happens into.
Well, they say the new approach must also recognise that in order to have primary care to refocus resources on prevention, outcomes rather than just activity need to be measured. So I guess there'll be a focus on outcomes and improving outcomes through the application of preventative strategies, is what the steer is here, I think. So as the GP contract is now entering its 5th year agreement, and the government will shortly be considering its intentions for the next iteration of the contract, radical reform is needed. So that's where a lot of these headlines have come with that word radical. And this is the right time to make it happen. So interesting language, radical reform and make it happen is interesting. Suggests pushing quite hard for this radical change. And then they talk about how should the right model be arrived upon, and they talk about convening a national partnership group to develop this new framework for contracting together, and they talk about including a diverse range of people, including the partnership leaders. I don't know whether that means people. I think that means people who operate in a partnership model, but partnership leaders. Yes, I think that's what it means. Who currently delivering excellent care, ICB, primary care leaders, local government, and also patient and public advocates. So trying to pull together a broad church. As part of this work, NHS England, DHS should, of course, engage with key stakeholders, including the BMA and the RCGP. So they do want to engage with them. But interesting, they're not part of this partnership group to drive it forwards. No. They're people to engage with, which I think is an interesting way of framing it and setting it up. Do you think that process will think that's the right process, Gandhi, and the right people to be consulting with?
I think it offers a different voice, and like you say, it's really interesting that the BMA and the RCGP have kind of been pushed into a separate category to be considered. I guess you and I could possibly be one of those partnership leader kind of thought people thing. Maybe we should be putting our hands up for it, to be honest. Maybe
I think
that's
people
something
really need to pay attention to this process, actually, because this is really, really key for the future of the profession. And I think as a call to action, we need to keep an eye on how everyone can engage in this process, and we have a role to play in terms of definitely letting people know about how they can be involved in that, and potentially contributing ourselves or through EGP learning viewers. And
this could be the next contract that we look at for the next few years. So our involvement is needed, shall we say.
Yeah. So she wants the right framework to enable the right systems to fit the right circumstances, building on the partnership model rather than sweeping it away entirely. So interesting that that's in there, and probably an acknowledgement that in some cases and some places the partnership model works. It's interesting. And then what is she directing this group to consider? So we're forming this group to look at the new framework for GP contracting. She wants to consider the outcomes we want from primary care. So again, that emphasis on outcomes rather than activity. To get that balance right between national specifications and local flexibility and decision making. So I think that's interesting. Specifically mentioning an increased role of PCNs to play in terms of reducing inequalities and population health management, and joining up the different elements of primary care, including urgent care. So I think, again, that's a nod to some of the suggestions about urgent and chronic care streams that were quite prominent in the Fuller report. National standards or specifications should include clear expectations around digital data. So there's a theme that runs through this document or the documents about using data to know how we are doing and to drive the right sort of change. So that almost goes without saying, and it's a small bullet point. Want to consider how to incentivize and support primary care at scale. So scale is where it's at, I guess. It's felt that way for probably the last decade, I think, in primary care, with a drive away from small partnerships, single-handeds. It's been increasingly difficult environment for them to operate, and people, I guess, are often doing better at scale, but not always. And it's talking about different ways. So it's just acknowledging that there's a broad church of ways of delivering primary care at scale, which might be freestanding practices working within a primary care network, not working with it outside a primary care network. However, practice coming together as a single group. So that's kind of group practices, I guess. Large super partnerships, GP federations are discussed as well. Interesting thing here, in future, the contract, whether for core GMS services or enhanced services, might be held with the primary care network rather than individual practices and partners. So that's primary care networks moving into delivery of core services potentially in the future. So that's an interesting change. There's lots of really quite big statements in here.
And I guess it feeds into that long-held belief that are the PSCNs created in an effort to try and create group practices effectively that are then more ripe to be taken over or run as a single unit rather than as various different units contributing to the whole kind of thing. So that statement, I think, fuels some of that perspective that that's what PCNs were originally created for and maybe have supported in achieving.
Yes, interesting. And how best, and also they want this group to consider how best to support struggling practices to improve. Yes, and where necessary, be replaced as well. So that implies maybe making it easier potentially for practices to be replaced rather than improved. I mean, obviously, where something isn't working, something needs to be done, and sometimes it comes to that sort of thing. But just interesting that that's there explicitly within the language.
Maybe Patricia Hewitt heard our episode about our predictions and mine about the fact that we're going to see more practice closures over the next year. So she's anticipating it. We don't know.
I think so. And then they talk about how can that be facilitated, because it can be difficult to change, to help. Sometimes people need to exit that partnership and so forth. So I think they're really thinking about how to
Yeah.
make that happen. So they're talking about creating a fund to buy out contracts, buy out premises, or both where they're not working. So that's interesting, and I think shows an understanding of what needs to happen when you need to change a GP provider, because they often own the premises and the premises is required by
Sure.
the next people providing the contract. It can get very sticky and complicated. Um, and that's the end of the primary care section, and probably worth just talking about a little bit more, really. I know we've got a few people watching, and Dave's already contributed. So interesting to know people's reaction to that. There's certainly a way of putting it which feels quite negative and threatening to GPs, particularly if you're sat, operating, a GP partnership led practice that works within a PCM but still has quite a lot of autonomy. There's certainly, I think, um, you know, a threat, probably a real threat to that level of autonomy that we currently have in terms of
Mhm.
the ability to be flexible, responsive to our populations. That exists within well-run practices, and there's definitely a threat to that, and a move of power towards ICS and PCN level. So interested to know what people think, but I guess what do we think, Andy?
I think, like I say, it's got some bold commentary in the document itself, and it definitely makes reference to those two key changes: that the GP contract needs to change and that QOF needs to change. And the question of what they will look like, it makes some suggestions. There needs to be, a focus on ICBs taking, responsibility, and ICS is taking responsibility for a lot of that change. Okay, it's written by somebody who works for an ICS. Yeah, conflicts, all that kind of stuff, and things that they're in there, I guess. But this is not something in that sense. I don't see that unexpected. What I do see slightly unusual is like you say, it's the tone that's taken with this document. It is very directive that this needs to happen, and it's unusual to see that kind of tone from these kind of documents and things. So it will be really interesting to see how the government does respond to this. Obviously, we're moving to a really complex time for the whole healthcare system. Also, we're in the midst of a variety of different strike issues and that kind of stuff. The local elections, potential national elections, all that kind of stuff, hampering a lot of change, unfortunately. Yeah, it's a bit weird, isn't it?
Yeah, we've had a few people respond already. Probably just worth thinking
Mhm.
about that. Dave says worries me, and it's big change. I think big change is always worrying. It worries me as well, because as I say, I operate a partnership model. I think we provide good care, actually, at our practice, and we're not small, we're not big, we're a reasonable size, and I think we have a good balance of agility and the ability to actually respond to our patients and their needs in the way that the system wants us to. And actually, I think they talk about, all these reports talk about moving away from a top-down model into more bottom-up, and I think we deliver bottom-up,
Mhm.
practice, and many practices do that very well. Um, Bridget's, I think there will be a lot of resistance about losing autonomy. I'd be interested to know, Bridget, whether you think that resistance is justified or not. Is it a good thing that there will be resistance, or not? I think you're right. There will be resistance about losing autonomy. Just interested to know whether people out there feel that would be positive, or whether that's negative. Can be read both ways. And I think Bridget just agreeing. Yeah, it feels very top down, quite worrying. They always say it's bottom up, but it always feels top down.
Yeah.
I mean, I think it actually represents a sort of a shift of power, really, to the middle, really, to ICSs, which are above us as GPs running individual practices, but they're shifting some of that responsibility and power from the national level to ICBs. Are they setting up another fall guy? Will they become the next primary care trusts or whatever went before, and just
Mm.
be labeled a failure and reformed away? And it's also pulling, I think, power up from individual GP practices to primary care network and ICS levels. Yeah, interesting thing about this in terms of power shifts. It's also pulling power, I think, away from the profession, uh,
Mm.
really, because there's certainly less prominent. Interesting that RCGP and BMA were left out of the partnership group deciding the future of contracting, and they will, of course, consult with them. That was really interesting way that was presented. So it's moving power away from our professional negotiators to a more regional level, and I'm not sure that the BMA will have capacity to support multiple regional.
No, I mean, that's a really challenging thing to do for any kind of footprint, isn't it? In terms of having multiple different contracts to manage, mitigate, understand. I see that probably more a role for the LMCs to really be involved in it, and therefore probably we do need a stronger LMC to support those kind of aspects, and that can be variable as well. LMCs are varied in how they support their local areas, so it's an interesting stuff. I think obviously we know that there's some other fairly heavy duty stuff due to come out soon. I do think that access report is going to be the big thing that's going to change more specifically what's happening, because that's, as far as I'm aware, being written by the government itself. So all of these are independent reports that we've been talking about. That's going to be the one that's actually written by the government itself and what they see as the direction of travel for general practice. So yeah, interesting to see what that looks like.
Yeah, and anything actionable in this report, Gandhi, do you think, in terms of preparing for change for GP practice out there?
Yeah, I think primary care needs to keep its eye out for when these calls come out of being engaged with the process. And I know that can be really difficult because many of us are, ostriching ourselves in terms of head in the sand, just trying to get through the day job and that kind of stuff. But actually, there will come a call, like you mentioned, Andy, for voices to be involved in this kind of stuff. And actually, you want to have the right kind of voices involved, not necessarily just the ones that are focused around ICSs and the managers who have the capacity to go to this kind of stuff. We actually want frontline grassroots, workers actually contributing to these kind of discussions and what do they mean and stuff. And that can be really challenging because, like I said, most of us are too busy trying to crack on with a day job. But I think, we're going to see a change in QOF. Okay, we're going to see a change in the way that we approach healthcare. And I think we are going to see that broadening aspect of moving towards the neighbourhood team being the unit of delivery of healthcare across the different footprints and stuff. And it's not going to be the practice anymore. We talked about this a while back, didn't we? The different units, like the Lego blocks and stuff. And I think, this is putting a real direction that unit of healthcare now moves away from it being practice. It now goes to PCN/neighbourhood teams.
Yeah, I think I'm just thinking about what's actionable as well. I think people need to be aware, not ignore. I think also probably prepare. It would be nice for people to maybe begin to engage a bit more with local LMCs, with BMA, with RCGP, who are the bodies that we can use to speak together on these issues to arrive at some. I think change is coming, and we need to just make sure that we arrive at something that is sensible. So we all need to be engaged, both individually, but we need to collectively engage. And I think those structures are the way that we do that. I think, and also it feels like primary care networks and that level are here to stay. So making sure that we engage with those locally as well, and that that those evolve in the way that we as local partners and GP leaders would want. So to engage constructively with each other and with primary care networks, because I think that they are obviously here to stay, be they primary care networks or network teams. Interesting thought here. I've not been through this report with a fine tooth comb, but I have had sort of a skim through and some of the things that are written about it. And I often think the underlying issue here is funding, demographics. The reason the health service is not delivering now as well as it was 5 years ago, 10 years ago, in my mind, is not because 5 years and 10 years ago we hadn't gone through this process of reform. Let me say that another way. It was functioning fine, or better 5 or 10 years ago, or at least that was everyone's perception. And people were, also happier in how they were delivering work, and everybody was more comfortable with what was happening. And that was before we embarked on this journey that we've gone on. So I'm not sure that the reason things have got worse is because we haven't gone further down this road fast enough of moving away from practice delivered care, moving towards quite complicated local and regional structures, which are going to have their own frictions and costs to operate. I don't think the reason why things aren't how people want is because we've not moved quick enough in that direction. I think it's because people are older, people are sicker, we don't have the workforce that we need. Funding has not kept up with inflation and the demands, and I think that's the reason why things aren't working. And we can't reorganize our way out of that. I think that we need to fundamentally think about how we value healthcare, people who work within it, and how we pay. Just thinking back, the junior doctor strikes happening currently, nurses strikes. I wouldn't be surprised if GPs don't strike soon. So this is just part of my reaction to it. But there we go. Any thoughts, Gandhi?
But not unheard of, and here to be honest. So I can see we've had some additional comments as well, Andy. So Bridget's mentioned, as you said, our partnership works well. Staff know patients very well. We know all our staff well. Bigger is not always better for patients. Valid points. There are some really unique practices that are working exceptionally well. I think there is something about economies of scale can be productive, but obviously it's also how it's ingratiated and how it's onboarded and that kind of stuff as well. And Jen the Littlest Hogo, great name there. It's a pass of the parcel responsibility. It's really simple. Give us funding and a direction to move in, and we'll get the work done. Stop changing the goalposts. How many times have we said that on the stream? The goalpost, general practice achieve something, and then they move the goalpost saying that you're not done well enough. And that clearly has an impact on how the workforce feels, the retention, the workload, everything else that keeps happening. And really interestingly, we're going to be covering that in our next kind of episode. So do make sure you jump in and join us. That's our review of the Health Foundation report, which specifically talks about, stress and that aspects of stuff. And if you want to also join us in a couple of weeks' time, myself and Andy are going to do a really extra special episode where we're joined by Ben Gowan from the General Practice Podcast and Tara Humphreys from the Business Healthcare Podcast as part of our PCN Plus organization that we've got to try and give you ideas and direction of what's happening in general practice moving forward as we review the actual GP contract and anything else that's come out in that time. So maybe the other reports are there as well, talking and trying to combine everything into this big mash of the future of general practice, I guess, isn't it, Andy?
Yeah, it's an exciting world, at least. Mm-hmm. So it'd be fun to talk about it.
Yeah, so if you do want to jump in and join us, feel free to do so. So we'll probably have that one coming up here in terms of the Health Foundation one, and lower down will probably the link to the episode talking about Ben and Tara joining us for PCN Plus. And as always, we're here to help tech enhance your primary care and learning. And we'll catch you in the next episode.